All right, today we have Natalie Winchell. She is from Olmsted, one of the best Suboxone programs in the state down in Olmsted. They're just crushing it down there. So she's going to be talking about some of their involvement in the opioid stewardship and the addiction medicine stuff. And they have lots of providers doing buprenorphine, so it's been great. So she'll be talking as soon as we're done.
All right, new slide. You'll notice I think we implemented this on the last echo, but if you have any cases that have come up that would be helpful for the rest of the audience, please don't hesitate to reach out to Katie and fill out a form so that this case can be presented for the group. I really feel like that's rich content, and if you have the question, it's likely that others may as well.
All right. So next week, in 2 weeks, I'll be giving the talk on 7-hydroxy and actually going to, there's just so much new stuff on 7-hydroxy literally in the last few months. And I have a really crazy case too that we dealt with here at our clinic. So we're going to talk about that. But 7-hydroxy is just fascinating stuff. And literally from the talk I did 6 months ago, there is a lot more information just in the last 6 months. So it'll be up to date in the last week. So and then, of course, we have Andrew Baker coming. So he's of course, always fun to talk about things from Hennepin County.
If you're super hungry and want to learn more about anything substance use disorder related, there's also other echoes that were listed on the bottom of the screen if you want to participate in those as well. Just remember that we're always here for technical assistance, likely have encountered similar situations, patients, or cases, so don't hesitate to reach out. Our contact information is at the bottom of the screen. We're happy to help.
Perfect. Oh, can you still hear me?
Mm-hmm.
Yep.
Wow, all of a sudden it got really quiet. Again, coming up on April 30th, our addiction medicine boot camp. Please give this information to anybody that would like it. It's going to be our clinic, myself, and was going to be Alex, but I believe she's going to be out on leave, and Erica, and then as well our special guest Cole Peringer. So we're going to be doing about 3 to 4 hours of didactic and then a bunch of cases, both hospital and clinic. It's all free. It's free CME. So please sign up. We have over 30 people already signed up in the first 10 days. So we're kind of shooting for 100. That's kind of where we'd like to be. So perfect.
Jordan, yes, absolutely. I saw your chat. Just know that Stratus Health is the home to the core website, so don't reinvent the wheel. Check here first to see if there's any policy or protocol examples that hit the target. Hopefully, there will be something that is content that can be used, so you don't have to create your own. Feel free to check it out.
All right. Oh, we're doing Zoom polls again. Which of these best describes your role? Provider, nursing, pharmacist, behavioral mental health provider, or other? Like if you're a veterinarian or a construction worker, that would be other. Chris, you can put other.
The all-knowing with the cat sweaters. That's what he needs. That's the buck he needs to check.
Chris is a pharmacist, but I don't really think he does the work, but we'll see. So mostly providers and nursing, although a lot of pharmacists today.
All right. As part of your role, you are working or have worked with MOUD patients. You don't work with MOUD patients, but you're interested in doing this in the future. You don't work with patients or clients, and you don't plan to, or not applicable.
I think next week, Katie, can we have a third one that's like, I have cats, I have dogs, I have snakes, or I have cats and dogs? Then we can see who the cat people are. All right. Wow. Everybody's doing the job. So that's perfect. All right, moving on. So we will let Natalie share her screen because I think she was going to. Again, from Olmsted, we'll have her maybe introduce herself and tell us a little bit about what she does. And feel free, please, to turn on your video. She'd love to talk to faces and not all of the black boxes. So don't be afraid to flip it on, even if you're eating. We don't care as long as it's good looking food.
All right, just making sure you're able to see the slideshow.
Yep.
Yes.
Okay. Um, Again, I'm Natalie Winchell. I am a pharmacist at Olmsted Medical Center. I've worked here for almost 9 years, so my role has kind of evolved throughout the time that I've been here. I did have a few learning objectives for today. Again, just kind of focusing on the pharmacist role and some of the different challenges that we've experienced in providing MOUD treatment and how we've navigated those. And then some of the stewardship activities that I've helped to lead at our organization. I first wanted to introduce Olmsted Medical Center. I think that kind of helps to get a understanding of our different facilities. So we do have two multi-specialty clinics in Rochester. We also have an acute care hospital and emergency department. And then we also have 12 community clinics throughout southeastern Minnesota. I did include the map here, and so the dots show where we have our clinics. This is a little outdated because we did just open a clinic in Owatonna as well, so we need to get that added. And then I just also included what some of our specialties are, and help to get a picture of who we are as an organization. So my role is my title is the Pharmacy Operations Manager, which is just kind of overarching. And so then when I try to explain what it is that I do, people are kind of like, huh, that's interesting. So I oversee our inpatient hospital pharmacy. I have our pharmacy purchasing department as well, so that those are the individuals that are responsible for purchasing all the medications for the hospital as well as our clinic sites. I am the operations manager for our infusion therapy center, our ambulatory infectious disease clinic, and then the medication assisted treatment clinic, which is what I'll primarily be talking about today. So with my role, I also lead or participate in a few committees at the organization. I lead our pharmacy and therapeutics committee, which oversees the use of medications throughout the organization. And then I lead our opioid stewardship group, which again, I'll be talking about more today. And then I participate in antimicrobial stewardship and quality and patient safety committees. So, I think working at a small organization allows you to wear a lot of different hats. And I personally really like that variety in my role. And I do think it's what's helped to facilitate some of the stewardship initiatives that we've done at OMC. So I realized I should have probably included a timeline slide here, but I'll do my best to kind of explain how we started our clinic and how that's grown over the last 6 years. So we started our medication assisted treatment clinic in 2020. And it initially was started with a grant, and I actually was kind of handed the department, being that it was largely medication focused. They kind of thought, it might make sense to have a pharmacist in that role. And so we started in 2020. We had a part-time provider, a nurse, and then myself. We utilized a lot of the tools and resources that Stratus Health has to help develop that program. And so when we opened in 2020, that provider did 2 full days a week and 2 half days. which we quickly realized was not going to be enough. And pretty much right out of the gate requested additional provider FTE. So we got to the point where we had Monday through Friday clinic access. Over time, we've adjusted some of our support staff. So we've had an RN and an LPN, and we're now at the point where we have 2 RNs in the clinic. We feel like that's the best fit just based on the complexity of the patients and some of the work that the nurses are doing within the clinic. Just having that RN scope is beneficial. In the graph there, you can see again how quickly the program grew. We currently do about 270 visits per month. Since we've opened, we've treated about 2,500 patients just within the MAC clinic. And then on an ongoing basis, we have about 220 patients that are active in the department. In 2023, 2024, we kind of started to plateau again with our provider access and our space. But we did add an additional 0.3 provider FTE, which you can see we had a little bit more growth in 2025. So we really feel like I think this is a good point of where we're at. Over the last couple of years, we've pretty much maintained at right around that 220 patients, just with depending on where patients are at within their recovery process. Some are needing to go to a higher level of care, or if they're choosing to taper off, we've just kind of always stayed right around that 220. So now that we're have that consistent practice in our Rochester-based clinic, we're focusing on how we can expand out to those other sites, and I'll talk more about that as well. So just to dive a little bit more, or into a little bit more detail about what our structure is and how it functions. So we do have 2 nurses, and they serve in that nurse coordinator, nurse navigator role, really focusing on that direct patient contact. So when you call our clinic, it does ring directly into the department, and it is the nurse that is answering the phone. Unless they're busy or at lunch, then we will have a patient service representative answer. But the majority of the time, it is a nurse that's answering and helping to guide patients through setting up their first appointment, and asking any initial assessment questions that might be helpful for the provider to know for that first visit. The nurses are also helping with that coordination of care and the transition. So if they're needing referrals to treatment, again, visit scheduling, the nurses are doing the scheduling of the visits. And then we often are getting referrals directly from the emergency department. So whether it's our emergency department, or if it's the other emergency department in Rochester, they will call directly to the clinic to set up an appointment prior to the patient discharging from the emergency department. I think this process is what really helps have that patient rapport, so that nurse is really building that relationship with the patient, and helping to help the patients navigate that process. So my role as the pharmacist and more on that operations side, is I serve as that clinic manager role, so helping develop any procedures that are needed within the clinic or nurse protocols, obviously reviewing staffing and performance reviews. But I think having that clinical background is what helps to facilitate any new treatment initiatives we're looking to implement within the clinic, and helping to facilitate that process. And then I really focus on the relationship building within the organization. across the department. So working with our emergency department, I do work out of the hospital quite a bit. So having that access to our emergency department providers, as well as our hospitalists, and then our surgeons, and helping to collaborate with family medicine or our specialty areas, and helping to coordinate, even if it's just a meeting for the MAT clinic providers to meet with one of these specialty departments to tell them, what the services are that we have. I think being involved in a few different aspects, I can see where there would be a benefit or a role to having our MAT clinic providers collaborate with those other specialty areas. And then also the ancillary departments. So whether it's billing, our laboratory, and then our retail pharmacies. So I try to help navigate facilitating those relationships, and addressing any challenges that we might come across when we're providing care to our patients. So I thought it would be helpful then to kind of talk through a few examples of some of the challenges that we've had and how we've navigated those, or maybe how I've helped in those challenges. So the first one here is a provider writes a prescription and the instructions are for split films. And then the retail pharmacy says they can't dispense it because the insurance doesn't allow for split films. So this was a issue that, it's the retail pharmacists that are reaching out to me because they know I oversee the MAT clinic and want me to talk with the providers about how they need to write the instructions on the prescriptions. And I think me knowing that the clinical, that it is clinically appropriate to split films, and unfortunately the prescribing information doesn't allow that. But that's a more payer level, state level challenge that we're also hoping will be addressed in the future. But just kind of helping to navigate those conversations. So being able to explain to the pharmacy, why the provider might be doing that, and then working with the providers on how we can maybe adjust our workflows to allow the patients to get the instructions that they need, and get their prescription. So in this instance, what we did was we had the providers write instructions that include that daily dosing limit of the films, and then within the after visit summary that the patients are leaving the clinic with, then providing additional instructions on how they should be splitting up those films. Another challenge that we had was within the department, the nurses were doing the prior authorizations for the long-acting injectables. When we first initiated doing SUBLOCADE within our department, our org prior auth department wasn't ready to take that on. And so we kind of took it upon ourselves. The nurses did a great job of navigating that process. It's not something they're super familiar with, so it was kind of clunky to begin with, but they worked through it and were able to do the prior authorizations for the SUBLOCADE injections. However, as our volume grew, we knew we weren't going to have the capacity to continue doing that. So then I helped to transition the prior authorizations within the department to our centralized prior auth department. So here at OMC, we have a team that does our procedure-based prior auth. So that includes surgeries, but then it also includes our high dollar infusions or clinic administered medications. So we worked with our prior auth department to transition that process to them, which then took it off of the patient care staff's workload. This was important to us as we were, again, our goal was to expand access to our branch clinics. And one of the challenges we had was how would we do that prior auth process if it was the RNs within the department who were doing those. So transitioning it to our prior auth department helped to then have a centralized way where no matter what clinic is ordering the medication, that they would be able to do that prior auth process. Oops, my lights just went off in my office. Let me dance around here for a second. There we go. And so this really allowed the patient care staff the ability to help patients then navigate, if there was going to be a delay in getting the prior auth, so they would then work with the provider on if the patient would need films while they wait for the prior auth, and just kind of being that patient support through this process. Challenge number 3, and this is something we're actively working on, is we've had patients that have been frustrated with how expensive their urine drug screen testing is. I've also had some of the higher up financial people at OMC, asking or evaluating our spend on urine drug screens. So we took that as an opportunity to see if there's maybe other options. So currently we utilize a pretty comprehensive urine drug screen with confirmatory testing, which isn't clinically relevant in most cases. So I helped to facilitate meeting with our lab to look at what other options we might have for urine drug screen testing. And then I partnered with one of our providers within the MAC clinic to evaluate those options that were presented from the lab to make sure we were still getting the clinical information that we needed, but hopefully at a more economical cost, both for the organization and for our patients. So this is something we're continuing to work on, and then once we have it implemented, we'll have one of the providers do education, both within the MAC clinic and primary care and our emergency department, on the utilization of the different urine drug testing that we have available. Another challenge that we sometimes see is when we have patients that can't afford their Suboxone prescription, or if they don't have prescription or insurance. So we are a 340B hospital, and so because of the patients that we serve, we qualify for the 340B program. And part of that program is we need, with the savings that we have, and we need to provide services directly to patients. And so one of the programs that we offer is a medication voucher program. Initially, when this program was implemented, we did not allow controlled substances for that voucher. And when we started the MAC clinic, we changed the policy to allow for medications for opioid use disorder. And I think, again, being a pharmacist and being able to help explain what the use is and why it's important that we get patients started on treatment was really what helped to push that change. So this program allows for a one-time 30-day medication voucher at the retail pharmacy. So from time to time, we do also have to do case-by-case basis of a second voucher, because a lot of times when patients are getting started on Suboxone, they aren't getting a 30-day prescription right from the start. So working with it's our social services department that oversees that voucher program. So working with them to, again, explain, that we only do short fills in the beginning, and if patients are actively working on getting insurance, that we may allow a second voucher as well. I think this works well because it also helps to get our patients connected to those additional services that might help with any financial concerns. So they're meeting with our social services department, or the business office to help get established with insurance or fill out paperwork, but also getting them started on treatment. So I think just to kind of highlight some of the strengths that I think help to facilitate these initiatives or navigate some of these challenges, the clinical knowledge of medications and being able to understand their use in substance use disorder treatment, I think is helpful in getting things done. I think pharmacists are also skilled in optimizing therapy, which no matter what area of pharmacy you've maybe worked in, typically involves dealing with patients that are having trouble accessing their medication. So whether that's you're waiting on a prior auth, or the drug is on shortage, or just some delay or if a patient's having a side effect, and being able to look for alternatives, and make sure there's no gaps in treatment. So I think being able to kind of troubleshoot and navigate that is a skill that a lot of pharmacists have. Good communication skills. So we're trained on counseling patients and educating them on their medications, but that also goes to educating our laboratory staff or our specialty areas that may not be as familiar with buprenorphine. So being able to communicate and educate not only patients, but other staff that we may be interacting with. And then the pharmacist role is ever evolving. There's always something new that pharmacists are doing. So I think it's inherently part of our role that we're adaptable, just kind of seeing where we can help and improve that and optimize patients' care. So kind of transitioning a little bit. So that was kind of more what we've done within the MAT clinic specifically and how our structure is. And then wanted to go over our opioid stewardship committee and some of the work that we've done and how I've helped to facilitate that. My role with the opioid stewardship group, I would say I kind of got known as the opioid pharmacist when the state, so when DHS had their opioid prescribing improvement program. So each organization had a liaison with the state to implement that program. And so I was OMC's liaison. So I helped to provide our provider information to the state, and then communicated with our providers at the organization when they would be getting their prescribing reports. And then if we had providers that were identified and needing to participate in that quality improvement program, I was a resource for them as well if they wanted that. And from that program, and in the next few slides, I'll show you a dashboard that we created, kind of just to continue monitoring our opioid prescribing data. And I think this is something that even without that prescribing improvement program that a lot of organizations are doing, there's a lot of payers that are looking at quality measures and involving opioids. So it's something that a lot of orgs are looking at. And so having a pharmacist involved could serve as a resource depending on what initiatives you're trying to focus on. Let's see here. So these next few slides kind of are a lot of information, but I just wanted to show you how we've structured our dashboard, and we do have a lot of metrics available. And most of these came from either um, our opioid management policy. So having a pain agreement and how frequently we require urine drug testing. Um, and so lots of different metrics that we can dive into and look at different departments specifically. And as providers have gotten more familiar with this data, they now may reach out to me to say, hey, can you help me look at this report and see why or how I can improve and get more patients that have been due for their drug testing or various reasons. But within our opioid stewardship committee, we are focusing on our chronic opioid use patients with concomitant benzos. So that is going to be our focus for this year. And again, kind of breaking down this data and drilling down to that provider specific prescribing information, and then we'll provide some education. So I think my role is I can have that conversation and then also provide some resources or alternatives to providers if they would like that. So I have a little bit more of the data that we look at. Within the last year, we also incorporated MOUD prescribing data into our dashboard with our goal of expanding our providers that are prescribing MOUD. We wanted to be able to measure that. So adding the outpatient prescription data and then the providers that are prescribing to our dashboard, this is relatively new for us. So, but it just kind of helps to see where do we have providers that are prescribing and where could we maybe do some outreach as well. And then again, just some more data that we look at on what's being prescribed to help with our goals and whatever initiatives we're working on. I think so. Clinical informatics is kind of another hat that I wear. Within our organization, we don't have a pharmacist on our clinical informatics team. However, anything that's built within the EHR has to be reviewed by a pharmacist. So I do end up doing a lot of that clinical review, whether it's a new medication, if it's an order set, or if we're developing these reports. So for example, the analysts will develop a report and let's say it's this MOUD report. They then would ask me like, okay, well, what medication should we be including in this? And we are an Epic institution, so Epic does have some, basic or foundation information that they'll include, but then they typically will have me validate or confirm what we should be including in that data. Let's see here. So kind of along with that and the clinical informatics piece is within the hospital setting, we do our order set reviews. So I participate in reviewing those order sets. So looking for any updated guidelines and providing recommendations specifically in regard to the medications. So for example, we just recently reviewed our alcohol withdrawal order set and made some recommendations to add phenobarbital to that order set, just as another tool in the toolbox. So now I'll help to provide recommendations on like what the dosing should be. And after we reviewed the alcohol withdrawal order set, I had one of the ED providers say, hey, can we have an opioid withdrawal order set? And I said, yes, absolutely. That would be wonderful. So helping to facilitate, get that opioid withdrawal order set started as well. Let's see here. So I thought I should have a slide dedicated to Sublocade because I know this is something that is challenging for a lot of sites. And I purposely tried to put a lot of words on this slide that some of them may be familiar, some of them may not. But these are things that I think a pharmacist maybe has a little bit more familiarity with, and may be helpful in navigating implementing long-acting injectables in clinic sites. So there's a lot of different barriers and challenges with implementing the long-acting injectables in the clinic. And so for me and how I've functioned at our organization, I am the authorized representative for the Sublocade distributor, and having the resources or knowledge on what the storage requirements are for having those in the clinic just helps to navigate that implementation. So there's a lot that goes into Sublocade. There's just a lot of challenges from the federal, state, payer level that, again, hopefully we'll be working on to reduce those barriers. But I think this is an area where potentially a pharmacist may be able to help assist in navigating that. So as I mentioned, one of our goals for our clinic is expanding MOUD. So we have been working on doing some clinic outreach with our branch clinics. So I included on the slide here, so this is our number of Sublocade administration. So you can see our MAT clinic, and then our Cannon Falls site we've recently onboarded. So what this looked like for us was doing some clinic outreach. So we did have providers that were interested and had some experience with Suboxone. And so I met with the providers, kind of educated on Sublocade, and they were like, yeah, we want to do this. So then the next step was meeting with the nursing staff and the support staff in the clinic to discuss logistics. So how do we actually get the Sublocade into our clinic? So being able to help them with that process, connecting them with our purchasing department, and guiding them through that our prior auth process. And then the way we do our administration competencies is we have the nurses or the staff at the branch clinic site come to the MAT clinic, and then the nurses within the MAT clinic provide education and do a skills competency on administering the Sublocade. And then we also have some provider-to-provider meetings to discuss any documentation questions, smart phrases. So I try to help facilitate all those different pieces so that we can have resources available to staff as they're starting this. And so far, it's been good, and now they're up and running, and we're excited to see how that grows, and then looking to expand to our other clinic sites as well. So this slide outlines kind of another hat, and it probably could be its own presentation in itself, but I think with my role, I try to take on a lot of that relationship building and that community involvement to allow the nursing staff and the providers to focus on that patient care and the patients that are in front of them. I do think depending on the structure or the other obligations, you could have the pharmacist more directly involved in that in the patient care as well. It's just with some of my other roles or other obligations, I'm not able to work directly with patients on a day-to-day basis. But I do think that is something that, depending on the structure of the clinic, would be feasible. I was just at the clinic the other day and the provider said, oh, I had a benzodiazepine taper. And he said he kind of was questioning what to do. And I was just like, oh, I want to help. I want to do that. So I think there's lots of opportunities to within the clinic that the pharmacist could be helpful. But so in another part is the community involvement. And I think this is where it's just kind of evolved over time with my role with opioid stewardship and within the MAT clinic. I participate in the county's opioid settlement core team. And I think this has been really beneficial because a lot of the organizations outside of OMC have they're directly involved with the patients that we're treating. So it's helped to provide referral pathways, and again, just knowing who to go to for treatment. So we've developed a drug and alcohol response team, and that team has reached out to me and to the clinic to help establish patients. We're currently working on an opioid spike response team, and in the early stages of doing overdose fatality reviews as well. And then within Rochester, we had a community health improvement project that was focused on substance use. So I participated in that. And some of the things we've done within that group is community education, whether it's on MOUD. We've had our providers do some education presentations for different committees, different organizations. We've also done a Kratom presentation, or the 70H, which is more recently. So just looking for ways that we can get out into the community to educate and then also provide our services as a resource. I participate in the Minnesota Hospital Association Opioid Stewardship Program, so helping to develop opioid stewardship practices, and we're currently reviewing those. If you're familiar with MHA roadmaps, working to update the opioid stewardship roadmap so that organizations have a resource they can utilize. And then I also participated in the DHS low barrier buprenorphine work group. And as I mentioned earlier, that was looking to address some of those barriers in access to treatment that hopefully we can look to address more at a state level. And so I think all of these things, and knowing that there are a lot of barriers that patients experience at the pharmacy level, has been beneficial to have a pharmacist kind of participate and provide guidance. Let's see here. And then this is just kind of a visualization of, I think I had a preceptor on rotations that drew this out on a whiteboard for me, but essentially kind of what I can do in my role as a pharmacist to help make the nurse's job easier, the provider's job easier, ultimately trickles down to the patient. So, whether it's getting the medication to the floor on time, and not delaying the nurse in administering that medication, or helping the provider order the Suboxone. I think just whatever I can do to help facilitate their roles ultimately leads to improved patient care. So with that was kind of a lot, but I'm happy to answer any questions or expand on anything that I briefly touched on.
Yeah, if people want to unmute and ask them, I think that's fine as well, or you can put it in the chat.
Oh, I see chats. Let's see.
I don't know if there's actual questions. There's a lot of comments. Okay. I'll ask the first question since nobody's jumping in there. But has your Suboxone clinic kind of bled out into other substances, so you're treating pretty much any substance around now?
Yes. So when we started, we said we're primarily focused on opioid use disorder and alcohol use disorder. But I think yeah, that has grown. And with the providers that we have in the clinic, as they've gotten more experience too, they're more comfortable addressing other use disorders. So essentially, we tell patients, or when the nurses are getting referrals, it's like we'll see anybody for an initial consult and kind of go through what options might be available, and try to help them.
There's a few new messages. How do you approach providers about possibly prescribing buprenorphine? Any pearls? Says Jessica.
That's a good question. We've tried quite a few different avenues. Any education sessions that are available, I've communicated to our providers. So let's see here. There's been a few different CME opportunities, and I just really try to make sure providers are aware of that. So I've sent that information directly to our emergency department or our primary care clinician leadership. And I think it just helps. Maybe if it's coming from somebody that they're familiar with, that then there's maybe a little bit more buy-in. So again, not recreating the wheel. There's a lot of education opportunities out there. So just trying to promote those opportunities. And then this is probably where the MAT clinic providers really offer that themselves as a resource. They're like, and that's been super helpful. So whether it's the emergency department or Cannon Falls, they're like, just give us a call. We'll help you walk through it. I think there's a lot of nuances or questions, especially when first getting started. So having somebody that you can call to be a resource and talk you through it, I think is what's been helpful.
Awesome. Natalie, are you willing to share your contact information in the chat?
Yeah, of course.
Natalie, when you start a program like this, I think one of the big things that becomes kind of causes a little confusion is urine drug screens and the results. Okay. And I'm just wondering if you could, are you one of the people that has become very adept at kind of interpreting them with the metabolites and the false positives and all that? Or is that the providers, or do you kind of step in there?
I would say that's primarily our providers still. Okay. And I do think that is something you could integrate the pharmacist into doing, but not something that I specifically do. So I think that's been helpful with when we were reviewing our urine drug screens, was partnering with the provider and to navigate that.
Natalie, I have a question for you. So you mentioned that the phone number is a little different for patients like calling for an appointment, and it's not probably processed through it just sounds like it's a little different. Can you explain that how do patients know the phone number? Mm-hmm. And can they go into their My Chart or whatever, and get appointments online? How do you communicate the process in which patients are calling for appointments, or that providers are maybe in other specialties are trying to refer patients over? Sort of what does that all look like?
Mm-hmm. So if you go search for our medication assisted treatment clinic, the number that's listed there is the number that's directly to the clinic versus if you're scheduling an appointment with primary care, it would maybe go to a central scheduling phone number. So, and that's, we want patients to be able to call directly to the clinic and get an appointment. And then I would say that working with our county and the community is where we've gotten our information out. So Rochester specifically has a Rochester Recovers website And we've worked with the county on establishing that website. And so it lists out treatment resources, and that's where where you'll find our MAT clinic phone number. And so I think it's, making sure your information is readily available within those types of organizations that are involved in different aspects of the community is kind of what helps connect patients, because they might not think like, oh, I'm going to go to my doctor's office for this. So I think trying to find those unique ways to connect with patients and let them know how to access treatment. And then let's see here. Then with referrals, so again, we worked to just really try to meet within our own organization, making sure like our OB-GYN department knows who the MAT clinic is and how to get in touch with them. But we also had, so Mayo Clinic, our other institution in Rochester, reach out to say, how can we make referrals to the MAT clinic from our emergency department? And that's where we said, here's our phone number and you can call prior to a patient leaving. And that's what has worked. We have explored electronic referrals but haven't implemented that.
Do you see as like other sites within your system start to offer this as well, like have MAP capabilities? Do you see keeping sort of the central line and they still call the central line, but you might be able to schedule that appointment in Cannon Falls or do you envision it probably being separate phone numbers sort of per location?
That's a good question. So currently, when we've typically started patients at the MAT clinic in Rochester, and then on a case by case basis, like, okay, it would be more convenient for the patient to go to this site, and so then working with them to transition that care. I think. So that's something we're kind of navigating, and it'll be, we'll have to see how it looks in the future. But I think regardless, it would, knowing that with the nursing staff and helping to triage those patients, and then they could help to identify like, hey, if you're coming from Cannon Falls, we do have a provider in Cannon Falls if you would rather be seen there. So.
Yeah, that's great. Thank you for sharing.
Mm-hmm.
I do think that one of the things, Natalie, having that direct line is so important. And I think here too, we have a nurse line that once patients are established, they have the nurse line. Imagine if you're running out of your meds, and you're early in your recovery and how stressful that can be, or you're in withdrawal because we can't. These are not people who wait on hold very well. And so really getting to the right person, I think what you've done there is just perfect, because the person that picks up the phone can help them. And I think that's such a key. I have one other question in regards to harm reduction, because I think, as we're spreading in our system, what constitutes good harm reduction in each site is a little bit different, or how people handle these things. Have you kind of dealt with that at all with, you having 5 providers in your clinic? Like, do they all look at like, well, if you have meth, I'm going to stop this, or, how have you dealt with some of those things?
We have 4 different providers that rotate through the MAT clinic. And I didn't explain that very well earlier, but so 2 of the providers work family medicine, and then they spend a day in the MAT clinic, and then 2 of the providers have the majority of the time in the MAT clinic. So I would say for the most part, I think their approach has been, they've all been on the same page with their approach. But I think just kind of having set points where we can all meet together to talk about either 1, if it's specific patients, or 2, just again, like how are we handling if there's meth in the urine. And I think they've all been on the same page of, well, we're going to focus on your opioid use disorder. And then if we can make some headway in these other areas, that's great too. But
Yeah.
yeah.
And important as well with one of the things we're looking at too is like some of our outlying clinics, their approach to that is different, and we have to have the same message, right? And so that is a challenge. It's a challenge.
Huh.
Yeah. Any other questions? Boy, fabulous talk, Natalie. Really a lot of stuff in there. Aaron, you didn't have a question today.
I don't. It's just great to hear more about your program and how you've taken a unique approach to get the work done in your community. So I think it's a great example of how we can all think outside the box. And if there isn't a provider that's interested or stepping up, how can the pharmacist really meet the needs of the community and the patients?
Mm-hmm.
All right.
And you guys said you guys give free Suboxone to patients that need it. Is that a facility-owned pharmacy, or are you using one of your contract pharmacies?
So with that voucher program, it is at our facility pharmacies.
There's some work for you, Chris.
The one we don't own, Kurt?
Yeah. All right. Well, being no further questions, we'll let Natalie get back to her workday. Another great talk, and really appreciate your time, Natalie.
Yeah, thanks for having me.
Thank you.
All right, everybody, next week, 7-hydroxymetragynine, the most fun thing on the block. It's a fun talk, and it's an interesting
I'll be there.
Yeah.
I'll be there.
It's interesting stuff. So,
and I'm going to register for the all day too.
Awesome.
The all day.
The boot camp.
The boot camp. I'm going to register too. I'm all the way from Tennessee.
Oh, really? Well, it's going to be tons of fun.
Yes. Thank you all.
Okay. Everybody have a good week.